presenting on artificial intelligence-based simulation platform for planning refractive surgery. Refractive surgery is a niche procedure demanding good quality and quantity of vision. Diagnostic procedures has made decision-making simple and has helped in avoiding complications. We used corneal topographers as well as biomechanics in order to plan the refractive surgeries, because corneal topographers give an idea of structure and the biomechanics about the strength. Here are a few case scenarios which are confusing. So which surgery would one choose in such confusing case scenarios? This brings us to our research question. Is there a way where we can choose the right refractive procedure? And is there a way where we can predict the outcomes of refractive surgery? For this, I need to first explain what is finite element method. It is a numerical technique that subdivides a large complex system into smaller and simpler parts. So we can study the simulated reaction to an action on these models. We translated research into practice and created this artificial intelligence-based platform by using FEM model and artificial intelligence on topography and biomechanics. How was it created? We made an inverse FEM model from the properties derived from Pentacam as well as Corvus. And then with the ablation profile and inverse FEM, we created a forward surgery specific FEM model. And with AI adjustment, we got the post-operative corneal stiffness. We simulated all the three procedures and we found that the predicted post-operative corneal stiffness matched the in vivo corneal stiffness in all the three procedures. We combined all these things into one software called as the AIOC2021-GP60-Topic-Dr.Sneha. AIOC2021 is a user-friendly software where we can start the simulation by clicking on refractive surgery simulation. We can select the type of the refractive surgery. Then we need to import the Pentacam CSV data and the Corvus CSV data. Once it is imported, we need to enter the refraction, the flap cap diameter, the optical zone, and then click on the Add to Run to start the simulations. Once the simulations are done, we click on the Recall Result tab to get the simulation report. This is how a refractive surgery simulation report looks. It has three bell-shaped curves, the orange giving the preoperative stiffness for a set of eyes, the green giving the postoperative corneal stiffness for the same set, and the blue giving the change in stiffness. The black line represents the patient in regard. It should be on the left-hand side of the spectrum to be normal. If it is on the right-hand side, it is a caution. So all these corneal stiffness were measured in Newton per meter, which is the force required to move a body by 1 meter. It measured the amount of force required for a specific amount of change and was different from deformation amplitude. Let's see a few case examples. The first one, we simulated all the three procedures. We found that the predictive post-operative stiffness was similar. We could plan any of them, and according to the clinical profile of the patient, we went ahead with SMILE, and the in vivo post-operative stiffness matched the predicted post-operative stiffness. For this patient, in the right eye and in the left eye, the change in stiffness was more in the left eye as compared to the right eye. For the same amount of refraction, the post-operative predicted stiffness was within normal range, but to be more cautious, we planned a trans PRK for the right and an extra procedure for the left. In this patient, the change in stiffness was similar for both the eyes, but the preoperative and the postoperative predicted stiffness were in the right hand of the bell-shaped curve, right extreme, whereas in the left eye it was normal. We deferred the procedure for the right eye and went ahead with phakic IOL, and for the left eye we planned one of the procedures. We have carried out a study which includes 529 eyes. We did the preoperative assessment, the software run, and the postoperative validation, and found a mean absolute error of 6.24 to say and 6.47, successfully predicted 7 ectasia eyes. Now we have among the number of surgeries that underwent refractive simulation, 57% were LASIK, 23% SMILE, 11% PRK, and 9% were phakic IOLs. We are planning to integrate the AIOC2021 into the existing corneal topographers. It is under beta testing across 20 centers. So it is the first versatile futuristic software. It helps in planning refractive surgery, predicting the post-operative stiffness. We are planning to incorporate a 3Z nomogram for contra vision planning, as well as the NXT UVF for cross-linking in thin corneas, which is an evolution. Thus, it is the pathfinder for refractive surgery planning. It helps in planning the refractive surgery logically, avoiding development of complications. We are planning to incorporate 3Z and NXT-UV, and thus the world's first futuristic versatile software. Thank you.
Beautiful. Thank you, Dr. Sneha. Excellent presentation. Could we have starting comments from Dr. Subhashish Nag, please?
Thank you, Rohit. Dr. Sneha, I must compliment you and your team for this futuristic work. Basically, AIOC2021, have you validated it with any other sort of group of researchers, this sort of software? which you have done from your institute?
So it is it is in beta testing across 20 centers in the world. So
Okay.
we are also planning our patients according on it, and even the 20 centers are doing it. It is the work in progress.
That's great. So it will be accepted worldwide then. And another thing, any difference in the group of patients? Suppose the ectasia is more in a group. Do you find reliability problem or some other differences?
Currently we have a patient who was planned on Accusimics, and now it has been he has come for after 2 years of follow up, and we are planning it very cautiously. For the patients who had developed ectasia, we had worked on it retrospectively, and we found that they were in the right extreme of our Accusimics report. Currently, we are going on very cautiously over it, and we pray for no more surprises.
So do you think it will help in preventing these surprises, ectatic?
So it would definitely, because while we were working on the ectasia patients, we got their reports worldwide, that we had also worked with the centers in Europe. And while working on these ectasia patients, when we stimulated them retrospectively, we found that they were on the right hand side of the spectrum. And currently, since we are going with it cautiously, we avoid surgery, we defer surgery for such patients.
Thank you. Congratulations again.
Thank you, sir.
Thank you, Dr. Nag. Any comments from Dr. Arundhati or Dr. Vanati, our cornea experts?
I think it's a very interesting concept. If it comes through, it will be very helpful for the refractive surgeons. So Sneha would like to see, I think, how you follow this up, very futuristic, I said.
One question to you, Sneha. How did you compute on, of course, I guess it is a software which is inbuilt, but what was the population with which you compared to evolve this simulation?
So, ma'am, we had incorporated 529 eyes initially, and now we are still including whatever patients we are adding up every day.
So you have used normative data of refractive surgery patients or refractory surgery patients' data of Indian eyes, and you have compared their biomechanical changes which have happened, and you apply this to your test population. Is that what I understand?
Yes, ma'am. It was.
Yes.
It included the Indian population as well as the patients who from the centers where this software has been given for beta testing.
Just for my understanding, how does this compare to when we are looking at patients for selecting and screening for refractive surgery, where we are not employing an artificial intelligence simulated software? How does this compare vis-a-vis our normal patient planning?
So, ma'am, we have come across a few patients who were absolutely normal in cases of indices. Like their corneal biomechanical indices were normal, but still when we simulated them, the change in the stiffness was so much for the amount of refractive error that they had, that it was going into the right hand side of the spectrum. And so thus we deferred the surgery in such patients, and even the patients whom we followed up retrospectively, the ones that had developed ectasia, we ran a simulation on their pre-operative scans, and we found the same change in them.
Thank you. Good.
Thank you.
Thank you, Dr.